how the adrenal gland was hyperactive. Now, what if the adrenal gland gets fried? Meaning your adrenal gland shuts down. What do you call that condition? Addison's, right?
Primary.
Addison's is basically when you have primary adrenal failure. Okay. Why does it happen? What is one of the most important reasons why somebody would develop, Addison's or adrenal failure?
TB.
Is that the most important reason?
No.
Then?
Autoimmune.
Yes, but again, people who have been on steroids and abrupt stoppage is one of the most common reasons. But if it really asks for Addison's disease, your number one reason is autoimmune. Yes. And what is the autoimmune reason? What is the autoantibody against? Is it 11? Is it 17? Is it 21? Is it 25? 26?
No.
It is 21.
Oh, okay.
It is 21 alpha hydroxylase. The autoantibody in Addison's is actually against 21 alpha hydroxylase. That's what does it. Okay. What are some other causes why somebody gets Addison's?
TB.
TB, which can infiltrate. Good. What else? Something else that can infiltrate?
Amyloid.
More of something else, not amyloid. Sarcoid. Sarcoid can do it. What else? Cancer, metastasis can do it. Okay. Cancer, mets can do it. What if somebody had, I'll give you a nice clue. What if somebody was started on a C5 blocker for a hematologic condition and you did not give them a vaccine or a prophylaxis? Neisseria meningitidis, if you had widespread infection, became septic from it, what does that do to your adrenal glands?
Adrenal hemorrhage.
It causes adrenal hemorrhage, which is called Waterhouse-Friderichsen syndrome. Okay, so that's another thing to think about. Waterhouse-Friderichsen. You all know I know the spelling, right? I'm just writing it like this because I'm lazy.
What did I say? What's capitalism? Is that not complement?
So she said caplacizumab. What is caplacizumab a drug for? How do you treat the antibody against the antibody that destroys Adam's factor TS13, which we used to treat TTP?
That's right.
Is caplacizumab. What is crizanlizumab?
Use it for anaplastic B-cell lymphoma. It's not PD-L1, it's PD.
What is the new treatment that you actually have for sickle cell disease, apart from hydroxyurea that's been around for the longest time? After hydroxyurea, the next drug you would typically use is L-glutamine, but now you have a new drug called crizanlizumab, which works against P-selectin. Anyways, so Addison's disease, right? If somebody is coming with Addison's disease or anything that's causing suppression of your adrenal gland chronically, right? You don't have to worry so much about it. How are you going to diagnose if you have got primary adrenal failure? What's the diagnostic test you're going to do on this patient?
Cortisol.
Insufficiency. Isn't that easy? It's very straightforward, right? All you need is 3 and 18. Shall we recap? You suspect adrenal insufficiency, you get 8 AM cortisol, right? If the 8 AM cortisol is less than 3, it's low. You have adrenal insufficiency. If it is greater than 18, it's good. So no adrenal insufficiency. If it is between 3 to 18, you're in limbo land. So you give them ACTH to stimulate the adrenal gland to see if the cortisol level goes up. If it goes above 18, no adrenal insufficiency. If it's below 18, yes, you do have adrenal insufficiency. Got it? Now, how do you treat if somebody's got adrenal insufficiency? What's your treatment?
It depends on in hospital or out of hospital.
So let's put it this way. If somebody's having an acute adrenal crisis, right? Something happened, the patient is hypotensive and you think this patient's got acute adrenal crisis. Are you going to wait to do the test?
No.
What are you going to do?
Hydrocortisone.
So you want to treat them, but is hydrocortisone the drug you're going to give? Is fludrocortisone the drug you're going to give?
No, hydrocortisone more than 40 milligrams. You don't need.
But you also want to prove your point, right? You want to test them. So let's put it this way. Say you've diagnosed a patient, like you suspect a patient has got adrenal insufficiency and you proved it, right? Now you want to start treatment. What you do is start them on hydrocortisone. How much? About 15 to 20, 25 milligrams of hydrocortisone for the day is what you would do. Do the test and prove it, you're good to go. If somebody's got septic shock and you think the patient's got critical illness induced adrenal insufficiency, in those patients, are you going to do all these tests? No. If somebody's got septic shock and the patient's on 2 pressors, okay, the idea is your adrenal gland reserve is out. In those patients, you need to give them steroids. What you do is stress dose steroids, but you don't think this is a permanent problem with the adrenal gland. This is a transient problem. There's been a study called CIRSE, corticosteroid insufficiency in critically ill patient, basically said do not test cortisol levels, just give them steroids directly. Okay, there's plenty of trials that have actually showed to actually give them steroids and they'll get them off pressors. Okay, so you don't have to do all of that in that setting. But if you're looking at an adrenal problem chronically or Addison's crisis, then this is the path you want to take. And remember to always, even your patients who you get sometimes and they have adrenal failure and are on hydrocortisone are here for something and they're sick, increase that dose because it's not enough. You have to go up. Are you going to go up on the oral dose or switch to an IV? Depends on how sick they are, or are they having a major surgery. But that's something to be always be mindful about. Hey, it's okay. It's okay. It's all right.